Dr. Metler is an assistant professor in medicine here. He's an internal medicine specialist, and he's actually talking about risk assessment for perioperative delirium. And with this, I would like to turn the time over to Dr. Metler. Thank you.
Thank you very much. Robert Minner, assistant professor in the Division of Hospital Medicine. I head up the inpatient medicine consult service here at University Hospital. And this is part of my LINCS fellowship. It's the Leaders in Quality Informatics and Systems Fellowship. And I'd like to thank my mentors, Dr. John Pell and Dr. Sri Raghavan, for their mentorship in this project. So this is a sort of a humble QI project in standardized risk assessment for perioperative delirium. So as part of the agenda today, I'd like to briefly touch on the background, the burden of perioperative delirium on patients and our healthcare system. Then we'll get into the current state of our workflows on the medicine consult service in the perioperative space, and certain quality gaps that we've identified related to delirium. After that, we'd like to, I'll detail our intervention that is proposed and different outcome measures that we will implement, as well as the QI plan. And then finally, just some future directions for the project. So what is delirium? So in the DSM-5, the most current definition is an acute change in attention or awareness that's a rapid change from a patient's cognitive baseline. And when we talk about perioperative delirium, that's usually in response to a stimulus in the hospital, such as an infection, dehydration, acute blood loss after surgery, or a multitude of other different stimuli. And so why is postoperative delirium a problem? Well, it's quite common. It affects up to 2/3 of all postoperative patients undergoing a procedure. Here locally at UC Health, system-wide, our quality metrics say that it's the 5th most common form of perioperative harm that we do to our patients. And that's at a system-wide level. Our rates are about 5.4% for all operative procedures. And we don't do as well as our peer institutions. Vizient data, we do about 36% worse in perioperative delirium. So it's something that we need to improve. Bad things happen to patients that get delirious postoperatively. In the literature, it suggests that it's about 4 days increased length of stay over non-delirious patients. And that's typically due to things like aspiration pneumonias, impaired medication administration, pulling of lines, falls that happen to delirious patients. There's 3 times higher risk of discharge to a skilled nursing facility rather than going straight home after the hospital. These patients are staying for weeks in rehab. They have a higher chance of dying at a year, a 17% higher risk of death. And there's a large burden to the healthcare system as a whole. There's about $60,000 per patient per year attributable to post-op delirium, and about $33 billion to the whole healthcare system. So it's a problem, and it's a good target for intervention because the literature suggests that about 40% of these cases are preventable through interventions that I will talk about in the next few slides. So a typical patient that we see on the medicine consult service in the postoperative setting here at UC Health is someone like this 84-year-old lady that I saw last year, admitted for an elective knee surgery. Typically, people should stay in a hospital 2 to 3 days after this procedure and go home. Unfortunately, on post-op day 2, she developed agitated delirium. She began to refuse all food, water, medications. She was placed in physical restraints, which is incredibly traumatizing for patients. Given Haldol, she developed an aspiration pneumonia, and she finally got out of the hospital 2 weeks later. Another case that is unfortunately quite common is an 80-year-old male coming in from elective spine surgery for back pain. should be in the hospital maybe 4 to 5 days. Unfortunately, on post-op day 3, he became almost completely unresponsive with a hypoactive delirium. We were unable to feed him, administer any medication. He had to have a nasogastric tube placed, was on tube feeds for 3 weeks. Psychiatry consult, Ritalin. Finally woke up a week and a half later and ended up leaving the hospital after 21 days for something that should have hopefully lasted about 4 days. So this happens a lot. And in the literature, these are certain interventions that were shown to help prevent postoperative delirium. Perioperative geriatric consultation, which happens whenever our medicine consult service is involved. It does reduce the incidence of delirium by 1/3 to 1/2. Certain intraoperative medications are under study, such as dexmedetomidine. But largely, the literature focused on interdisciplinary non-pharmacologic interventions. And these are bundles of care that together have been shown to reduce the incidence of postoperative delirium by as much as 40%. And these are things like cognitive reorientation, sleep enhancement, early PT and mobility after surgery, correcting visual and hearing deficits for elderly patients, non-opiate pain management, correcting things like dehydration, appropriate medication usage and removing deliriogenic medications, and then treatment of constipation and hypoxia. So taken together, these can have been shown to prevent the occurrence of perioperative delirium by about 40%. Fortunately, at University Hospital, we have an order set that implements most of these interventions, and it's called the Inpatient Delirium Order Set. It contains a myriad of nursing interventions, much similar to what you see on the last slide, including frequent reorientation, sleep hygiene, monitoring for things such as urinary retention, and patient education. When we implement this order set, it also ropes in pharmacy to identify and remove deliriogenic medications from their list. It contains commonly used laxatives, non-opioid pain management, and non-benzodiazepine sleep aids. So this contains many of the evidence-based recommendations within this order set. At the medicine consult service at UCH, we do both traditional general medical consultation and also surgical co-management, and that's for orthopedics, trauma surgery, and the neurosurgery services. And as a result, we're very well positioned to screen high-risk delirium patients. We're actually automatically consulted for geriatric trauma patients, as well as geriatric hip fracture patients. And typically, the surgical services will involve us for most of their elderly and medically complex patients. Just a word about co-management. So that's a model of consultation we use where we are consulted typically directly on admission to the hospital before the surgery. The consult will include a perioperative risk stratification. So we look at the cardiovascular risk, the pulmonary risk, and also the delirium risk. We follow these patients daily, we see them daily, and we are able to write orders and manage medical issues as sort of a co-primary team, working directly with the surgical team. So what can we do better? Our current state is that faculty on our service don't always assess delirium risk if they're not using our evaluation templates. It's often assessed in non-standard ways and non-uniform ways, and as a result, we have an inconsistent use of preventive measures. So the quality gap is largely in standardization and consistency. So our ideal future state would be that all providers use validated risk assessments to assess delirium risk, and the result of that would be our preventive measures would be used appropriately on the correct patients. Because these, as you can guess, this order set is fairly time intensive for the nursing staff, pharmacy staff, and other people who are caring for the patients. So in our current state, like I said in the previous slides, our delirium risk, there's not a lot of guidance for faculty on how to assess the risk. So we wanted to get a sense of how people are actually assessing the risk of perioperative delirium on our service. So we created an EPIC-QI workbench with an SQL query. We took basically the patients from the first quarter of 2022, about 300 initial consults to orthopedics. And we asked, what were our faculty hospitalists actually using to assess their risk of delirium? And we found that most people weren't using a validated risk score. About 3% of people actually used an objective measure. Some people used medications, which would typically make sense. Some people use old age. But about 2/3 of the faculty did not explicitly state how they assessed the patient's risk of postoperative delirium. So we searched the literature for a validated delirium risk model. There are many such models for perioperative delirium. We wanted one that was not too time intensive to perform. As a QI project, one of our goals is to maximize adoption of this QI measure. And so we wanted to avoid increasing attendance time and workflow more than it already was. So trying not to require a change in the attending's workflow by obtaining additional variables. We didn't want long assessments such as the MOCA and nothing that involves advanced computation. So we settled on a model out of Columbia University that was basically a risk score to predict postoperative delirium in patients with hip fracture, which we are extrapolating a bit to a broader category of orthopedic patients. So the component variables in this risk model are 9, and each is weighted a bit differently. There's the presence or absence of preoperative delirium, preoperative dementia, age, whether it's medical co-managed or not, the ASA class, functional dependence, whether the patient is an individual who smokes or not, what the presence of infection, and finally, whether they use a preoperative use of a mobility aid. So currently, we're in the process of working on a clinical calculator. This is, a typical note in EPIC, and this is how the clinical calculator would look. Attendings would just have to fill out these buttons on the left-hand side, and it would output a percentage risk of delirium. And so our cutoff, if the postoperative delirium risk is greater than 5% is our initial cutoff, we would say that delirium precautions should be instituted via that order set that we described earlier. Our project timeline, we're going to have a 3-month pre-intervention baseline data collection period. Then we will implement the risk calculator and have a 3-month post-intervention period. We've identified both process measures and outcome measures for this QI project. In terms of process measures, we'll be monitoring the percentage of faculty who use our perioperative template, the percentage who actually complete the risk calculator, and then the amount of people who order the delirium precautions order set. And in particular, it'll be stratified into people who order it for low-risk patients inappropriately, and we also want to identify missed opportunities in where they're not ordering precautions for high-risk patients, and see how this changes before and after our intervention. And then for outcome measures, we're going to have an attending determined subjective measure of delirium. Is the patient delirious on a given day, yes or no? And then fortunately, system-wide, we're just now implementing a Q-Shift CAM documentation for nurses for all patients 65 plus. So we'll be able to use that as an outcome measure, whether the patient did have documented delirium by nursing assessment. Some limitations of this project. The risk score was only validated for hip fracture patients, so we are extrapolating it somewhat into a broader orthopedic population. However, we do think that most of these variables are relevant in a broader surgical context. The population is a bit narrow. Only co-management patients will be first studied. So there is some selection bias in that the orthopedic and trauma surgeons only consult us on their more complex patients or elderly. And then there remains the dilemma of how to measure whether a lot of these nursing interventions are actually getting done, because we can measure whether they were ordered, but whether a nurse actually is cognitively reorienting someone is a little bit harder to measure. And then future directions, we would ultimately like to improve a risk calculator and create our own version, which we can validate with our patients. Several groups around the country have used machine learning to derive their own variables, and it's a strategy that I would like to pursue in the future after our first iteration. We'd like to expand our patient population to other surgical subspecialties beyond orthopedics and trauma surgery. And finally, we'll obviously like to test additional interventions for the prevention of perioperative delirium. And with that, I'd like to thank everyone for your time and open up for questions.
So, Rob, thanks for that talk. So what % of patients do you see on the consult service would have a predicted probability of post-op delirium of greater than 5%?
So that's a good question. I don't have the data for that. I would say we're probably overshooting the amount that we're going to implement delirium precautions by using 5% as a cutoff, because typically, I guess anecdotally, a lot of patients will have several of those variables that we're consulted on. So I think initially I'd rather overshoot things and maybe see a signal, and then we can cut down from there.
Do you think it'll be the majority of patients versus?
Yes, I think probably over 75%. We'll probably have over a 5% risk of delirium.
Because the question there is, right, if the majority of the patients are going to have post-op delirium, would the default be better to say these are patients that don't need the RISPR and give everybody the intervention unless you really think they don't need it, right? Because if you think you're trying to improve the care of a high-risk patient population that has high morbidity, then maybe everyone should get it, and then it's the small minority that don't need it, right? Where you're trying to save I guess it just depends on kind of what you're trying to do. And it seems like if the majority of the patients are going to have post-op delirium, then the default should be everyone should get that package rather than, trying to have physicians select who gets it or not.
Sure. Yeah, that's actually a good point that we can look into.
And from an implementation perspective, in terms of nursing workflow, that is probably easier than dividing people up willy-nilly between rooms to actually say, here's 5 people who don't get it as opposed to everybody else getting it. It's easy to establish a workflow on the floor, I think, if it's more consistent.
It probably adds a lot more work to them, but it's easier in terms of thinking about who needs it.
Yeah, that's great.
And that's the other risk. If it's everybody, the compliance with an intensive intervention will likely be a very time-consuming intervention, is likely to be lower, perhaps.
Right.
So that might be another outcome to consider.
Oh, yeah. Okay.
Yes. First, I want to say appreciate that you didn't use the term smoker. You used someone who smokes, person who smokes. But the other question I have is, how effective is this prevention package? I mean, how much decrease in delirium would you expect in response to the preventive measures?
Yeah, the data that I've seen is basically that a bundled package similar to the one that we have, when instituted at time of admission to the hospital, resulted in between 30 and 40% reduction in incidence of delirium. But you're right, we don't have internal data about effectiveness. I think one really great thing is that as a healthcare system, they've just made the decision to institute these CAM assessments for every nursing shift for every patient above 65 years of age. So I think we can start to do a lot of outcomes data even at baseline, and then given that those are just going to come into play this year, so maybe we can figure out that. Go ahead.
So I realize this is a QI project, but is there a way to, because you're really not able to measure currently whether any of those preventive interventions were done, but is there a way to combine some observations of selected patients so you could capture both were they done as well as how much of a burden is it on the nursing staff to implement these? I mean, if it's a 5-minute thing that they do and it reduces delirium by 30%,
Yeah,
it's clearly going to be worth it to the hospital to take into account the need for that extra 5 minutes for their nurses. So, I mean, it's a opportunity to try to do a lot more around the implementation
yeah,
and really what would be the benefit to the hospital as well as the patient.
I think that's a great idea, and we should probably look into it at somehow, some way to measure whether it's actually being implemented on the sub. Maybe we could just do like a biopsy of a certain number of patients on the ortho floor.
I just randomly select some patients for a research person to sort of
Yeah,
check.
and also, I don't know if that could be a survey to nurses, or on average, how much time do these interventions take, and how effective do you think they are, things like that, or to quantify their burden.
That is an option. It's not the best, but it'll give you at least a sense.
Yeah,
The response rate on that would probably be, response rate on surveys, generally, optional surveys is generally in the range of 30% perhaps. So the response rate would be very low. So I don't know how much data you'd get from that, as opposed to actually having these sort of case studies where you have someone following up and looking at the times that the nurses has charted meds and contact with the patient and implementation of the protocol. It's a hard question to answer when you don't know what the baseline is.
I bet you'll learn a lot by following them around.
Yeah.
And you might find that some interventions are more high value than others, or the nurse probably will be able to tell you, well, I think, XYZ is probably more important than of the checklist.
that's a good point.
And the question is if the nurses all have competency in some of these more behavioural interventions, the orientation, diurnal orientation type things, and if that's being delivered equitably across staff, which is a very hard thing to do for any measure, but there are data showing that if people don't feel like they have the adequate training and competency to deliver and any kind of interventional service, that they're less likely to actually do the tasks assigned because they don't feel empowered or educated or competent to do them. So that might be another area, if you're going to do a survey, to maybe add a question like that to the survey.
Yeah, thanks a lot.
Is there an age-dependent risk?
I'm sorry.
An age-dependent risk?
Delirium? It's definitely a known risk factor. I don't know, what the likelihood ratio as age goes up for it, but it's included in almost every perioperative risk model for delirium. So I would say definitely.
Kind of makes you not want to go into surgery.
Well, thanks everyone. Thanks for all.
Thank you very much.